I am the Executive Director of Tambo Foundation. It's a pleasure and honor to have you listening in. And to those who would listen later, we hope that you take a thing or two away from this conversation. So for this Lifting the Veil series, we're looking at navigating reconstructive surgery, some of the myths, some of the realities, and I have the pleasure of hosting a renowned plastic surgeon, Dr. Yemi Ogunleye. Without further ado, I'm going to go ahead and introduce Dr. Yemi Ogunleye to all of us. He is a plastic surgeon with general surgery training and an interest in cancer reconstruction, with specific expertise in clinical epidemiology of cancer and surgical treatment of lymphedema. He chose a career in oncologic reconstruction and breast cancer reconstruction in particular, due to his belief that the possibilities for making patients whole again are infinite. Dr. Ogunleye has been involved in breast cancer advocacy as a medical student, breast cancer research as a graduate student, and breast cancer care as a surgical trainee in general surgery and plastic surgery. He has worked on a variety of clinical studies in his career and coordinated a multinational, multi-center surgical randomized control trial, which was published in a top 5 journal in medicine. Dr. Ogunleye was part of the group that published the first surgical epidemiologic papers in breast reconstruction from the ACS National Surgical Quality Initiative Projects, NSQIP. He has also applied his epidemiological skills in publishing systematic reviews and pooled analysis. He has the benefit of a general surgical training with a clear understanding of both the oncologic and reconstructive aspects of breast cancer care. And so who better to be with us today than Dr. Yemi Ogunleye. Welcome aboard. It's a pleasure to have you. I think you're muted.
Happy to be here. Thanks for having me.
Thank you. So without further ado, we're just going to jump right in. I remember when as you're well aware, I'm a breast cancer survivor myself. And part of my treatments 7 years ago from stage 3 breast cancer also involved a mastectomy and a breast reconstruction. And at first I thought, oh, it was just going to be right off the pack. But then when I sat in front of the plastic surgeon and they began to talk about some of the complications and the process, my jaw dropped. But nevertheless, it was a teaching moment. And so my hope and goal for this conversation is that a lot of women of African descent, African women in particular, those on the continent and in the diaspora who might be considering reconstruction, will get a thing or two from this conversation. So my first question to you, Dr. Yemi, for many women, the idea of breast reconstruction might feel overwhelming. What exactly does it involve? What does breast reconstruction involve? Are there different types of reconstruction that a patient can choose from? And how do you or your colleagues decide whether reconstruction should be immediate during mastectomy or delayed?
Thank you very much. There are wide variety of reconstruction options. We typically tell people they can be divided into two ways, and that's a simplification. Really, there's a lot more than that. But in general, we think in terms of implant-based reconstruction, where you use implant, silicone or saline to make the breast, or autologous reconstruction, where we use your own tissue from a remote site, like the belly, the buttock, the thighs, to reconstruct the breast. So those are sort of like two different groups. Now, there are groups that are in between, where you could use a bit of both, but in general, those are the two broad groups. Reconstruction can also be immediate, where the reconstruction is started on the day of the mastectomy, or it could be delayed, where the reconstruction started on a different date than the mastectomy. This could be weeks later, months later, even decades later. Those are all possible options. Now, in terms of who gets immediate reconstruction and who doesn't, it sometimes depends on the urgency of the cancer treatment, availability of operating time for both the cancer surgeon and the plastic surgeon, as well as, other issues that are going on with the patients who are actively smoking, patients whose diabetes is uncontrolled, patients whose nutrition is very poor. They're probably better served by having delayed reconstruction.
Interesting. Okay, so this now goes to my next question. So for those that are immediate, what you're saying essentially is that all the health factors have to be ducks in a row. So there are certain things that you're looking at before from a health perspective. So blood pressure looks okay, BMI looks okay. What else are you looking at that it must, for us to have immediate reconstruction, this is this? Like, are there comorbidities that you're looking at to determine that this patient will be ready for reconstruction immediately after mastectomy? So if a patient came to you now, like, okay, sorry, you cannot go for reconstruction, maybe you're overweight or your blood pressure is too high or everything.
So like you point out, health is a very large continuum. It's a huge number of different factors. So it's hard to give you a list of all things that we think are a bad idea for, immediate reconstruction. And because of that, every patient is an individual. And so you have to use your judgment to identify what you think, is a risk that is going to compromise their care. And you have to remember, when we advise patients, say, for example, to go for delayed reconstruction, it's really not so much that we can't do the operation safely. In some cases, you can actually even get the operation done and get the patient, do okay after surgery and go home. But you have to remember that a fair bit of breast cancer will require adjuvant therapy, which means additional chemotherapy, which means additional radiation. A patient who gets a healing complication from a reconstructive part of their procedure cannot proceed with the remaining of the life-saving care that they require. And so it goes beyond, I can do the operation fine, and you go home the next day, and then you get a wound that you got to nurse for 8 weeks. Mm-hmm. And that 8 week maybe is your radiation window. And if you don't get that radiation in that 2 to 3 months, then we're stuck in a place where, all the cancer cells that are left in the area then get a head start. And so the consideration is really not just, can we do the operation safely? Can the patient do okay and go home? It's also, can we get them healed and ready in time for any possible adjuvant therapy that they will need? And so it is specific to the patient. There's too many things that can be, an issue with healing. And those are typically the things we're looking for. Patients who are taking immunosuppressants for rheumatoid arthritis. Like you said, patients whose BMI is very high, they can't heal properly. Patients who are still actively smoking at time of cancer diagnosis. There's a lot of different things. And so every patient is a singular person and has to be evaluated based on experience. And then the shared decision-making can take place.
Thank you very much for that response. So in addition, I wanted to also ask, so you did mention earlier that you could either do saline implant reconstruction or you can take tissues from the patient's body. Is there ever a time when you decide, okay, it's better to do saline as opposed to taking from the patient's body, or is it a 50-50 equal success rate?
Again, this is very specific to patients. Some patients have adequate tissue in other sites. Some patients prefer not to have implants. In general, for reconstruction, actually silicone implants are more common and more desirable than saline implants, because silicone implants feel more like your own tissue versus saline implants that tend to feel a little more like a water balloon. And so saline implants sometimes are slightly better for women who are getting cosmetic breast augmentations than they are for people who are getting reconstruction after a mastectomy, because they don't quite feel like your own tissue. But that's just by the way. Every patient is different, and it's not just, there are some patients who are only candidates for one type of reconstruction. Let me give you an example. So a patient who, for example, has already had radiation after a mastectomy and is getting delayed reconstruction cannot just have an implant reconstruction in that breast. They have to have some tissue to replace the damaged radiated tissue. So even if they get an implant reconstruction, there has to be an autologous component to it. But in general, it's a discussion that we have. What does the patient want? What does the patient qualify for? And then we sort of come to a middle ground.
Thank you, Dr. Ogbole. I hope you don't mind me calling you Dr. O for the rest of this.
That's fine. I go by Yemi most times, so that's all.
Okay. So Yemi, that's it. So, I want to go into the myths and misconceptions and fears. Breast cancer survivors sometimes often fear that reconstruction may trigger cancer recurrence. Is there any truth to this? And also, some women believe that reconstruction is only cosmetic. And what would you say to them? And there's also the issue of medical complications such as autoimmune issues or breast implant illness. Do you mind elaborating and discussing on this topic?
Yes, so breast implants are safe. We've been placing breast implants for north of 50 years. There are people who complain of immunologic symptoms. This is not well described. There are no tests to diagnose breast implant illness. And in some of these patients, if you take the tissue out, they say they feel better. And some, you take the breast implants out, they don't feel better. And so, like any operation or any procedure that you get has a risk of complications. But just the same way that we all get hip replacements and knee replacements when we get older, we get pacemakers when our heart, malfunctions. Breast implants do exactly the same thing. They're not any different.
Thank you. So I am well aware, I've been a big follower of your work and some of the wonderful initiatives that you do on the continent. How accessible is breast reconstruction currently? I know you work in Sub-Saharan Africa, Nigeria, for example, but please do go ahead if you're able to speak to other countries on the continent. How accessible is breast reconstruction right now for breast cancer patients on the continent? I know here in the US, insurance, at least, the law has made it mandatory for insurance to pay for breast cancer patients to have access to reconstruction surgery. But on the continent, in Nigeria, what has your experience been?
Yeah, so the continent is 53, 54 countries. So it's not just one thing. In some parts of the continent, it's slightly better availability of breast reconstruction. So in South Africa, as well as in Egypt, some of these countries, you do have some reconstruction going on. In Nigeria, unfortunately, it is limited to a few centers. But some of the team that I work with in the University College Hospital do perform reconstruction from time to time, depending on what, OR availability is. Unfortunately, it's not reconstruction, breast reconstruction is not covered by any of the insurance policies. So typically patients have to pay out of pocket, as is the case for most care in a place like Nigeria. Most patients are paying out of pocket, but there are opportunities to get breast reconstruction for people if they seek out these centers and get evaluated.
So essentially, if you're a low income earner, you are sort of the lower income class, and you survived breast cancer, you did the surgery, breast reconstruction might be out of reach then.
That is correct. There will be, depending on where you live and so on and so forth. We're looking at a situation where maybe only two locations will, have options for breast reconstruction within the country. So depending on where you're living and how much you can afford, yes, it is not available in most of sub-Saharan Africa.
So what would you say to our policymakers about making reconstructive surgery for cancer patients available? I know we've come a long way. I mean, it's interesting this year, for the month of October for breast cancer awareness, there was a lot of activity in Nigeria. Almost every state, there were walks, advocates came out. So in the awareness space, we're seeing sort of a swelling. But then we have other aspects of continuation of care within the breast cancer spectrum and continuum. So what would you tell our policymakers, NGOs, communities, what should they be doing?
So yeah, I think, civil society in this country was really responsible for the 1998 Women's Healthcare Act, which mandated breast reconstruction for all health policies. And I think civil society will have to do a similar job for most sub-Saharan countries, where the women come forward and say, this is a problem that's increasing. It's a demographic thing. It's a lifestyle thing. As we become a slightly more advanced society, and we live longer, we're going to have abnormal cells. And, we can see that rise. If you look at the epidemiology of breast cancer in Nigeria and other sub-Saharan countries, more and more women are getting this problem. And as we get better at screening, as we find, cancer early and we treat it and we save women, then we have to make sure that they live a full life and they can be restored back to their pre-cancer status. And so I think that, not only the policymakers have to consider and include, reconstruction in their plans for health and for cancer care. I think on the other side also, I think, nonprofits like yours and other parts of civil society, the Medical Women's Association of Nigeria, these sorts of organizations also need to get involved in advocating to at least extend healthcare coverage and create opportunities for surgeons to train and provide these services for our women.
Thank you. So I want to go on to my next question, which is the recovery process. What is, for a woman who would like to undergo reconstruction? Because I think for me, I remember, I was in what, I don't know if I should call it a fool's paradise, thinking, oh, it probably won't be as worse as a C-section recovery. And then when the surgery was done, the first surgery was done, and I had to carry drains for 3 weeks. It was the most emotionally and mentally, it was tough. So I want you to speak from the perspective of a medical provider, but not for me. Like, what are the expectations? What expectations do you set for patients in terms of recovery for breast reconstruction after a mastectomy?
I think recovery is different for different individuals. The most important factor in my mind for recovery is pre-morbid, that is pre-surgical condition. Someone who's healthy, running every day, who's eating well, they're going to recover faster from surgery. Somebody who's slightly less healthy is going to take a longer time recovering from surgery. And then on top of that, somebody who gets neoadjuvant chemotherapy is going to even have a tougher time than somebody who doesn't get neoadjuvant chemotherapy. So it's individualized, and it's a discussion that you have to have with individual patients and say, this is what we expect. And we educate patients. We tell them these are the things that will help you do better. Eating well, lots of protein after your surgery is going to help. Staying hydrated, making sure you're, managing drains if you have drains properly. You're following restrictions related to lifting and reaching. All of those things are important, and lots of social support. This is not a one-person game. You have to have people who can help you.
So let's talk about the social support. So how would you advise families to help support what sort of support structures should be in place for a woman who is looking to undergo breast reconstruction after breast cancer surgery?
I think it depends on what procedure is done. Each procedure has slightly different levels of support. Typically, using your own tissue has a longer recovery time, needs more support. Using implants has a faster recovery. You don't need quite as much support. But regardless of what kind of reconstruction you get, you do need to have someone available to, drive you to your appointments, to help you with your drains, to help with dressings, help even with just basic cooking and stuff like that in the house. If you have younger kids, somebody to help them, with all the activities that they need to go to. So I think really having, especially in-house family is critical.
Okay. So back to a more policy-making type question. How do you see in the next 5 years, how do you see reconstructive surgery, especially in the space, evolving in Nigeria? Let's use Nigeria as a use case. Any glimmers of hope?
Yes, I think so. I think if you looked at things, say 15 years ago, almost every woman who was diagnosed in these parts of the world was diagnosed stage 3, stage 4, later stages. Now, even some states like Lagos State have screening programs where people get mammograms regularly. And so they're picking up much more earlier cancers, and women are surviving longer. And as women survive longer and in a better state, then we can move reconstruction forward. Also, the availability of implants and the availability of reconstructive techniques and people who can do that has continued to improve. And I think in the next 10 to 15 years, more and more people within our setting will provide cancer reconstruction. And I'm happy to be one of those people who are helping hopefully train that generation of surgeons.
Thank you. So you struggle between the US and Nigeria. Excuse me. If a patient wanted to see you in Nigeria, usually, what's the process?
So I currently actually don't provide clinical care in Nigeria. Most of my work in Nigeria rarely involves training surgeons and junior doctors to perform some of these procedures. But I will occasionally be able to go and help maybe local surgeons. If people do need to reach out, I think if they were to reach out through your foundation, we might be able to connect them with people on the ground or let them know when we go out. Whenever I do go on a teaching trip, and see if we can set up an opportunity to have a discussion.
My other question, though, so in terms of the supply chain dynamics for reconstruction products, what's that space looking like in terms of ability to procure, the implants and whatnot? What does it look like currently?
It's challenging but possible. It is possible. Like you probably know, in these parts of the world, if you can create the resources or get the resources, typically you can find anything you want. It's just a matter of time and having the resources. It's not a run-of-the-mill thing that's done every day, but with planning, it can be done.
Thank you. Welcome on board to those who are just joining us. We have with us Dr. Yemi Ogunleye, a renowned breast reconstructive surgeon from North Carolina. If you have any questions, please go ahead and type them in the chat so that when it's time for Q&A, you can have your questions answered. Once again, welcome and thank you. So my next question to you is about the next generation of reconstructive surgeons. How do you see, or I want to talk about sort of viability. Do you see more of our medical students looking to go into oncology and specializing in reconstructive surgery? Has there been a marked shift, or are people still going through the usual suspects, general surgery, pediatrics, and whatnot, and everything? So, how niche is it?
I think the sort of reconstructive practice in Nigeria is in its early stages. I think in general, most folks are still training in plastics, but the majority of plastic surgeons focus on the biggest burden of care, which is trauma and burn surgery. However, at several of the tertiary centers, there are people who are getting additional training in these complex reconstructive procedures.
My next question to you is that what message of hope do you have for women currently facing the decision of reconstruction? And also, do you see yourself sometimes referring some of your patients for psychosocial services, maybe due to body image issues and whatnot? So how do you navigate that whole process?
I assume you're talking about in my practice here. So practice here, the patients are part of a cancer care group, and part of that is providing psychosocial support. So even before the reconstructive consult, they typically would have been screened, and those who are interested and need psychosocial support will have been referred to a counselor as well.
Okay. And so by the time they come to you, the psychosocial aspect of things have been handled.
That's not to say it's handled. It's continuing care. They may have had a referral, and someone will have set up an appointment to speak to them. And if, for example, when we see them, we identify these sort of needs, we will also make the referral. But it's a cancer center setup, and that's the beautiful thing about it. And so it's not just people working in silos. There are geneticists, counselors, cancer surgeons, reconstructive surgeons, nurse navigators. There's a whole group of people.
Thank you. So I actually have a personal question to you, and I don't know if this is a question that someone is asking. I remember when I had my first consult with my plastic surgeon. So the breast cancer was on the right breast. And the surgical oncologist determined that I was just going to have a single mastectomy. But I thought it would make sense to do a double mastectomy to even out for symmetry. But the plastic surgeon she vehemently said there was no need to touch the left breast because there was no cancer. And she was of the opinion that recovery will be much longer, and that why trouble the breast that has nothing to do with it? So I want you to speak to that. If you're looking for symmetry, because the truth is, over the years, it's been very hard for me to attain symmetry. The instruction she gave me was to go lose 30 pounds and then come back and do a lift. It's been 7 years. I've not been able to lose the 30 pounds yet. I'm on endocrine therapy and all the complications that come with that. And so, what do you say to me or any other woman in my condition that's like, okay,
yes,
I would love to have symmetry, but
yes,
you're saying that.
I understand. So of all the things that when we talk about reconstruction, we describe the goals for breast or any breast surgery in general as size, shape, and symmetry. Of the three, symmetry is most important. So I understand where you're coming from. However, I also understand where the cancer surgeon is coming from. Like we said, we're trying to save lives. And so if you get double surgery, it's double the risk of complications. Double the risk of complications means we can't get to life-saving additional treatment. And so we need to keep the complication risk low so that we can treat the cancer. Once we're done treating the cancer, frankly, if you want to have another mastectomy, that's fine. For most people, that is. I don't know. I can't speak specifically to your case. And you also have to understand that I'm not a cancer surgeon. So, but I do know that literature shows that if you do not have a genetic abnormality, the risk of recurrent cancer in a woman who has a primary cancer is the same whether you take out both breasts or you take out one. In people who have a strong family history, genetic history, genetic abnormalities, then for sure the risk of a new cancer or whatever in the other breast is high enough to necessitate a bilateral mastectomy. But it is important to make sure that we can get patients to adjuvant therapy and we keep them alive. So it's almost like there's a gradient of there's a pyramid of needs, and keeping you alive tends to come just ahead of symmetry. But we would typically like to get to symmetry too, right? And so eventually we will, on most of my patients, we'll get to the point once we're sort of out of the cancer treatment bit, we can come back and address the other breast as the case may be, or even perform a bilateral reconstruction after the contralateral mastectomy. I hope that answers your question.
Yes, it does. Thank you. So on to my next question. I know that technology is always advancing. So I'm just wondering, are there new technologies or new advances in breast reconstruction that are out there these days?
Yes.
And the other question I also have,
so
the saline implants that are available now, I hear some are for 5 years, but you can use them, you can push it to 7 years or 10 years. How healthy is that?
Like I said, implants are healthy. They're just like a knee replacement, a hip replacement. Most of the hip replacements and so on, they say maybe after 10 years they may fail. But the majority of our silicone implants, again, which we recommend for reconstructive purposes, their life, if they don't have a problem, you don't have to mess with them. People keep them forever. If they have a rupture, they have an issue, then we will operate to take them out. But the majority of them will live as long as, and they'll function fine for the rest of the patient's life. Now, saline implants are a little different. They have a slightly higher, they're more likely to need replacement just due to their nature of being saline implants. But even then, in people who don't have problems with them, we don't recommend you take them out. So if somebody got a saline implant, if I put a saline implant in somebody, either for cosmetic or reconstructive purposes, and they're happy with the way their breast looks and everything looks fine, and they're 20 years, I'm not going to go tell them take it out. We only remove them when there are problems with them, or the patient has an asymmetry issue, or they develop scarring, those sorts of things, which can happen. But if there's no problem with it, there's no indication to go do more surgery.
Okay. So if what you're saying now is, if the expiry date, if for lack of a better word,
there's no expiry date.
Okay. So if an implant, I'm trying to phrase this correctly. If it's 7 years and I'm still pushing it to year 10, year 11, it's still okay. That's what you're saying.
That is accurate. A long time ago, people believed that the shelf life of implants was 10 years. And after 10 years, you have to take them out. That was in the 90s, the implants that were made in the 90s. The implants that we use now do not require you to do anything to them if there's no problem with them.
Okay, that makes sense.
You will only intervene if they are ruptured, or if the patient has a complaint, they have scarring or contracture or something. If there is no issue with your implant, you do not have to do anything to it.
So my other question though, in terms of scarring and scar tissues, so are you saying that scar tissues don't build around the implant and there's a need to shift things around and clean things up?
That's correct. If most people have a very pliable implant capsule and they don't have any problems, a minority of people will have what's called capsular contracture, which is abnormal scarring, and that will typically require surgical treatment.
Okay, thank you. If you have any questions, this will be your opportunity to type your questions or send them over to us, put them in the message app. Again, we are looking at Navigating breast reconstruction. Okay, I see that. I have a question here. Do you see the difference culturally in your practice? So here's a
Yes.
question. Yeah.
Yes. So culturally, like, people's sort of body image goals are different in terms of breast size, in terms of body shape, and so on and so forth. So you have to keep that in mind sometimes as you perform reconstruction. But it's not just ethnically based; it's individually based. Reconstruction is individually based. You're going to get some white patients who would like to have larger breasts, C, D cup breasts. You're going to have some African American women who would like A cup breasts. It really is individual. And so while it's important to think about those ethnic differences, I think, finding what the patient actually wants is probably even more important.
My other question to you, are there any lifestyle changes that a woman that has breast reconstruction should consider?
I think yes. In general, everybody should consider lifestyle changes that promote our health. And there are very few things that are specific to breast reconstruction, to be honest with you. I think in general, someone who's got breast cancer should look into improving diet, increasing exercise, you know, those sorts of increasing physical activity, those sorts of things. I think they're going to be helpful both from a heart health point of view to a cancer point of view, and they're the same for reconstruction. I don't know that there's specific things that we're going to say you should do just for your reconstruction. I think it's the whole patient.
Have you ever in your practice had to tell a woman you don't see them qualifying for reconstruction, not because of inability to pay, but maybe because, what factor would make you say it is not safe to do reconstruction?
As we discussed, typically there are comorbidities that pre-exist the cancer. Somebody who has uncontrolled diabetes, somebody who has uncontrolled blood pressure, somebody who's on immunosuppressive medication, somebody who has absolutely no help at all.
So no help, diabetes, high blood pressure.
Those are specific examples. There are lots of other things that could be, that would make this a bad idea.
So what will emotional healing be for that kind of person? What will healing for that person be like if, we cannot offer you reconstruction?
At this time, remember that is at this time.
Mm.
So that's what I think people need to remember. So what we're saying is at the time of cancer treatment, okay, that adding that in the mix is not good for the patient. It's not recommended. That's all we're saying. We're not saying you're never going to get reconstruction. We're saying let's get your cancer treatment done and let's perform delayed reconstruction. So that means that person has to go through a phase where they do not have a breast form on the one side. And we typically will support people with also getting prostheses and setting them up with fittings and so on as they sort of pass through that phase to get to the point where they now have the resources and they're in a better place for reconstruction.
So I see a question from Oloyede Ola. It's a real one. So he says, Doctor, what's the percentage chance of surviving in the process? Are you saying surviving the breast cancer reconstruction surgery? Is that your question? Okay, yes. So what are the complications that can happen during? Let's talk about that. During reconstruction, what are some complications that can happen?
So like any surgery, you can have bleeding and infection. In general, an infection is a bigger issue with implants because if an implant gets infected, sometimes it can be difficult to save it without removing it. In fact, in most cases, you will need to take the implant out if it is really infected, and then go through a phase of healing before you start again. But in general, I think that survival, which is the point she's making, is excellent. It's very rare for somebody to die from mastectomy or from reconstruction. So if I may answer Ms. Oloyede's question, the answer is almost everybody survives. 99.9% of patients will survive. Now, the question then is, not just survival, but also healing without complications related to these infections, bleeding, wound healing. And that varies depending on the individual. And those rates of problems, those complication rates can go from as low as 5 to as high as 35% of women.
Thank you very much. We welcome your questions. So while we're I have a question for you, sir, about, patient decision-making and preparation for surgery. Are there specific questions that a woman should ask before choosing a reconstructive surgeon? Because I'm in the advocacy space right now, and one of the things that I've noticed is that people want to ask questions, but they don't know the right questions to ask, or they don't know what to ask.
Yes, I think that's the importance of sessions such as yours. That's the importance of survivor groups, whether they're on Facebook or wherever. Those are all places where people can go to and get information. Also, at our center, we will perform or will offer patients an education session with our nurses where we go over some of the basic things. I have a presentation also that we can go through. Just talks about all the possible options so that you go into your consult with the plastic surgeon with the information that you need. In terms of choosing a reconstructive surgeon in the United States, we have a body called the Board of Plastic Surgery. Typically, you want your plastic surgeon to be certified by the board, or at least to be eligible by the board, which means they've had the requisite training to work performing plastic surgery typically. And whatever, country you're in, typically also in West Africa, there's the Nigerian College of, Surgeons, and there's the National College of Surgeons, and there's the West Africa College of Surgeons. You want your surgeon to be certified by one of those, or to be a fellow of one of those colleges. So typically you want to make sure that whoever is doing the procedure is trained to perform those procedures.
Thank you very much. I was booted out a little bit there. So Folu said in Nigeria, we've heard a lot of scary news. Is there an opportunity for regulatory bodies to improve safety standards for procedure or implants, in Nigeria?
I think that there's always an opportunity for us to improve regulation. It's the same thing in the US as well, where you have people who may not quite be certified surgeons, or who may be trained in a different kind of field, performing certain kinds of, either reconstructive or cosmetic procedures. So definitely regulation to make sure people only do what they're trained to do is important. I think in terms of implants, I think we have a really good system in the US for especially making sure that devices are sterile, that they're used for what they're supposed to be. I think that's less developed in sub-Saharan Africa. But that said, I think there are, organizations, there are regulatory bodies like NAFDAC and so on that actually register all kinds of devices that come in the country. But they may actually have the opposite problem, which is that they don't have the resources to verify and check and have a robust inventory of devices, medical devices in particular. So they're a little better with consumer devices, but with medical devices, they actually act more of an obstructionist situation because they just don't have the staff, they don't have the knowledge. And so sometimes they just default to, corruption because they really can't provide anything else. So I think there is an opportunity to build out some of the regulation with medical devices in a place like Nigeria and some of the West African countries.
Mr. Oloyede has another question. After the reconstruction, will it perform all the functions that it has been doing before the main surgery, or is it just for fancy?
Yes, so it's important to know that reconstructed breast will look like breast and will feel like breast when patients have a good reconstruction. The woman can't use it for breastfeeding, of course, because the breast is actually gone. The breastfeeding part is the part that causes the cancer, so we have to take that out. But otherwise, they tend to do the same thing in terms of how they look in clothes, in terms of how the partners feel, and so on. And in some cases, women will get some sensation back, and it can also be helpful for intimacy as well.
All right, we have another question here. How complicated or realistic is it for patients seeking breast reconstruction in instances where they had previously sought plastic surgery for beauty purposes before breast cancer and eventual mastectomy and eventual need for another breast reconstruction procedure? So
this is in patients who have had cosmetic surgery, then get breast cancer and require reconstruction. It makes it slightly more difficult, but it's totally possible.
could you repeat that? Sorry, I missed that.
So having had cosmetic breast surgery before breast reconstruction makes the breast reconstruction slightly more challenging for the surgeon, for the patient's recovery, for everybody involved, but it is possible.
Okay. Okay. There is hope. All right. Okay. So my next question for you, let's talk about the self-esteem issues a little bit more. And please forgive me if it looks like I'm going into couples counseling territory, because I've had, in terms of patient navigation situations, where patients, they've been diagnosed with breast cancer, they've had a mastectomy, but because of body image issues, they're not feeling whole, and it's affecting the home, it's affecting the relationship with the spouse. What do you say to such, women to destigmatize the shame that they might be feeling, to get them to get help?
Yes, I think that this is one of the reasons we perform breast reconstruction, so that, again, people can improve their body image, can feel more confident in their body and in their relationships. And I think that if you have women who have such issues, they should approach their cancer team and ask to speak to a site. And they will work with not just the patient, but also the partner to improve, some of these relationships, and also help such a patient getting to see a breast reconstruction surgeon, or at least improve things as may be possible.
So in your practice, have you had to sit with a partner before to talk to them? Sorry, you're muted, Dr. Yemi.
Yes, so most of my patients actually come with their partners to their reconstructive, because like I said, you need a lot of help. So if you involve people early on, it's much easier to get that help. So typically they will come with their partners to their consult appointments, and it's a joint decision making. The education is there for both of them, and they go through the process together. And so that's not unusual. However, if they have a marital disharmony, typically that will go on to the counselors.
Ooh, so many questions, so many answers. I would like to say, okay, thanks for the opportunity, but we would like to know the stages and process for victims that wish to reconstruct to go through. So, real one, I'm trying to understand your question. You would like to know the stages and process.
Let me actually pull up a presentation now that we're here. I think that might just help to cover some of these bases.
Okay.
So there goes. 1 second.
Opportunity to share his screen, please.
I'm working on it. If you give me 1 second. Window. Okay. Share. Okay. Okay, so I'm going to have to, I think this isn't showing up exactly how I would like, so I'm going to have to, okay, that should be a little better. And so this is just a little talk that has some imaging that I think will also be helpful for our listeners. So this is just a talk that focuses on breast reconstruction. And first, this talks about the fact that there are lots of possibilities. The considerations include things like, your past breast cancer treatment. So somebody who has a recurrence has already had a lumpectomy is a little different. Medical history, we've talked about, BMI, diabetes, previous surgeries, we've talked about past cosmetic surgery, their current breast size and their desired breast size, what medications they're taking, if they smoke regularly or not, and what kind of support you have and what your goals are. And this is the Women's Health Act, which was placed in law in 1998 by President Bill Clinton and his team, which means that essentially states that all insurance policies need to cover breast reconstruction in women who have had a mastectomy. So in the US, so long as you have insurance, you can get your reconstruction covered. The reconstruction choices could be immediate and delayed. I discussed that already. You could also have reconstruction at the time of the lumpectomy to make the breast more even. Patients could choose to go flat, where they have the breast removed and keep the chest flat. And they could have implants or expanders placed. They could have tissue from their back or tissue from their belly. They could have tissue from their thigh for their breast. It's important to know that direct to implant means that we place the implants on the same day as the mastectomy. And this is typically for women who are getting immediate reconstruction. For these operations, women typically will want to have a similar size to their current size. They will want to have, no major comorbidities or medical problems. But first, we check to make sure there's good blood supply after the mastectomy. So not a lot of patients will qualify for this, but for those who do, we'll be happy to perform that. In West Africa, we don't typically offer this sorts of surgery because there are slightly fewer resources, especially related to the meshes that we need to use. We can also place a tissue expander on the day of surgery, which is a temporary device that eventually gets switched around to an implant after complete cancer treatment, like a placeholder. The implants or tissue expanders can be placed under your pectoralis muscle or on top of your pectoralis muscle, depending on the preference of the surgeon or the patient. And the implant choice, we talked about this, could be saline or silicone. Typically for reconstructive purposes, silicone tends to feel more like your own tissue and is typically preferred. After surgery, most patients will need about 4 to 6 weeks to heal from breast implant surgery. They'll need to wear a bra 24/7 during that period. There will be drains that you will take home. There will be dressing changes. You won't be able to drive when the drains are in place. Like we discussed, no lifting or reaching above your head for 4 to 6 weeks. So these are some pros and cons of implant-based reconstruction. It's the most common reconstruction performed in the United States and in Europe. Hospital stay is usually only one night. The recovery is 4 to 6 weeks. And the cons are that if you do get an infection, you may require the implant removal for a period of time. Also, in women who require radiation after mastectomy, implant reconstruction is more likely to get complications related to asymmetry. And they may require revision in the long term. This is an example of somebody who has had reconstruction, who was trying to be bigger, had a mastectomy, had implants placed the same day. And using your own tissue typically involves using muscle and skin from your back in what is called the latissimus dorsi muscle, or using your abdomen, what is called the deep flap or the tram flap. And this is a little schema that shows the tissue coming from the back and coming to the front. The surgery for the latissimus dorsi typically takes 3 to 5 hours. The patient will require a tissue expander or an implant because most people don't have enough tissue in their back to make a breast. So in addition to that, they require a breast. Most people stay 2 to 3 days in hospital, and it takes about 4 to 8 weeks to heal from it. It's important to sort of keep your arm pressure off the trunk initially, and these are the possible complications. And this is an example of somebody who is before cancer surgery, and you can see what they look like with placement of an expander initially and radiation. And then in the bottom, you can see what they look like after they've had reconstruction using tissue from their back as well as an implant. You can see that their symmetry is similar. And here's an example of somebody who, and this is talking a little bit more about using your own belly with a deep inferior epigastric perforator flap. And we use typically tissue below between the belly button and like the groin line or C-section scar. This is a much bigger operation, can take us anywhere from 6 to 12 hours, stay in hospital 3 to 5 days, and it can take 3 months to recover with your core. Typically, we'll want people to have lower BMI so that they can have better healing with this operation. Pros are that it's your own tissue. If you gain weight, it gains weight with you. If you lose weight, it loses weight with you, which is something that an implant doesn't do. It's your own tissue also. If you get an infection, you just take antibiotics to get it better. It may give more of a natural appearance of a breast. It will sag with time, just like the natural breast sags. So they tend to feel and look more like a breast. But it is the largest surgery up front, and you will require a lot more support during the healing. And there is a small risk of issues with blood supply. And this is an example of somebody who had delayed reconstruction again. There's a scar after a mastectomy, and this is what her belly looks like before surgery. And when we reconstructed breast, this is what she looks like. This is another example of somebody who has cancer with a delayed reconstruction, again, with a scar before surgery. We reconstruct the breast with the belly, and you can see what she looks like after that. And when eventually, once the breasts are exactly how the woman likes and she likes it, we can reconstruct the nipples using either a tattoo or using the skin of the reconstructed breast. We've talked about restrictions, no housework, no driving long distances, operating machinery, no submersion in water, typically for a couple of months at least. Normal postoperative changes after surgery include some of these things, but eventually they all settle down. And here is contact information for me, and I'm happy to answer your questions.
Shall we all just give a resounding clap emoji for Dr. Yemi? Thank you so, so much. Thumbs up, claps. Thank you, thank you, thank you, thank you, thank you. This has been very, 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 very informative. This has been quite a lot, and I'm thankful that we were able to explore the whole spectrum from the patient perspective, policy perspective, the need to have more civic societies having conversations around this to make this service available for women on the continent, and for us to even use our voice and echo our voice. So you have given me, as a social entrepreneur, something to think about and see how we can join forces with those who are on the continent to continue to push for policies around this. Thank you so much. God bless you.
You're welcome.
And that joined us, thank you for spending your time with us. You could have been anywhere else. This session is recorded and it will be available on our YouTube channel once it's edited and good to go. Once again, I am Oluwatoyin Adewumi. I'm the Executive Director of Campbell Foundation. And it's been an honor to have you all here. Have a wonderful rest of your day. Bye for now.
You as well.
Thank you. Bye.